All right, welcome back to day one of our virtual critical access hospital conference, our sixth annual Stroudwater here. If you're just joining us, welcome. If you are joining us from a prior session, welcome back. We're going to close day one with a session focused on the broader transformation happening across rural healthcare and the strategic decisions leaders must make in response. So we have Eric Schell, who's the board chair at Stroudwater Associates, and John Downs, board member of Stroudwater. Have spent years working alongside rural hospitals on financial strategy, operational improvement, facility planning, and long-term transformation initiatives. Together, they bring both strategic and operational perspectives shaped by direct experience, supporting rural healthcare organizations across the country. So, as reimbursement models evolve, financial pressures intensify, and delivery systems continue to shift, rural hospitals are facing critical decisions about structure, service lines, facilities, and their long-term positioning. So in this session, Eric and JD will explore what effective rural strategic planning looks like through the lens of transformation. The discussion will focus on how rural leaders can strengthen long-term sustainability while aligning operational, financial, and facility decisions around the needs of their communities. And the attendees, we hope, will walk away with practical frameworks for evaluating readiness, aligning leadership around transformation priorities, and navigating industry change with greater clarity and confidence. So take it away, JD and Eric.
Excellent. Thanks so much, Keith. I'm actually quite grateful that Eric did finally join us. I was a little bit nervous for a second that he was having a technological challenge as we did this, because those of you that know Eric, Eric's been in rural healthcare since there were rural places and since healthcare came around. I think it was sometime in the 1840s that he joined Stroudwater to start this rural practice. And Eric has given this presentation hundreds and hundreds of times, but every single time it continues to evolve. And so I've been with Eric probably for 100 of these, and not one of them has been the same. Many of you on the call have probably seen this presentation in a previous form as well. And you may know that sometimes it goes 90 minutes or 75 minutes. Eric has been nice enough to tell us he will get it done in 60 minutes today. We may have time for questions at the end. If we do, that's fantastic. If we don't, I encourage you to put questions directly into the chat. Those will be accumulated and sent over to Eric, myself, and others at Stroudwater, and we will answer them. We will answer them all. You will hear back from Eric with an answer to your question. So I encourage you to use that chat. But I'm very excited to just hear it again because I learned something every time. I will chime in every now and again, but I'm going to kick it over to Eric right now. Mr. Schell, why don't you get us going?
JD, thank you. And thanks, Keith, for introducing. Uh, Good afternoon, some. Good morning, others. Great to be with you. We're going to kick off is what many of you know as the Shaky Bridge Talk. That's what this is. And some of you are saying, as kind of JD alluded to, boy, we've heard this before. And what's interesting is this year I've probably given this talk a dozen times already because there's a renewed interest in the message. I'm not sure what it is. Maybe it's a result of OB3, maybe it's some other things, but more and more people are interested in the content of this presentation. And so a little bit about what it is. It's the first part of the presentation is where the market's going and why we think the market's going in this direction. That's number one. Number two is why we think rural health systems have incredible value in this new world. And the third part of the presentation is if we know where and why the market's moving in a certain direction, if we know we have value, what is the best means for rural health systems to be successful through this transition? And so with that, we're going to kick that off. Again, as JD said, it's going to be landed. If we finish in 60 minutes, it's going to be an absolute miracle, but we're going to give it a go. So the market's moving. And there's a number of kind of reasons why we see that the market is still moving and accelerating. Cost of healthcare. We'll talk a little bit about why that impacts the market movement. Advances in technology, growth in the Medicare Advantage plans, and the impact that they're having on we in the healthcare system. Changes in volume that we're seeing, and then finally, kind of where the federal government is in all of this, and all of these result in a market that's accelerating. So the first is health insurance premiums, and I gotta This is every year Kaiser Family Foundation puts out a study looking at the health insurance for an individual and then a family of four. If we look at the green line, which is healthcare insurance for a family of four, back in 1999, the cost was 5,800. Today it's $27,000. And if you look at the last 3 years of premium increases, they're not slowing down, they're accelerating. And so economic theory says that when a price of a good or service goes up, two things happen. The first is the supply of new entrants looking to come in and provide this service and make a profit goes up, and the demand for a good or service goes down. So if we break those two into separate pieces and we say, okay, demand is the price of something goes up, the demand goes down. Well, to some degree in our industry today, with the exchanges now, kind of somewhat taken back with the impacts of HR1, but employers in a tight labor market looking to step in and subsidize insurance premiums, to some degree, we've created a fake demand curve for the product health insurance. And so demand has stayed constant. Well, the other side of that, the supply. So as the price of a good or service goes up, more market entrants come in to try to, essentially rebalance the price of that service back to its marginal cost. Well, the new market entrants this timing of new market entrants happens to coincide with this incredible accelerating growth in technology. And this is it's somewhat of an age slide because it doesn't factor kind of what's going on with AI right now. And JD, you wanted to comment a
Yeah,
little bit
I mean,
on
I think
this.
the crazy thing to think about here is, this wild hockey stick. I mean, thankfully, the Kaiser Family Foundation slide doesn't go at the same level of increase over the last several years. But this goes back from, the printing press in the 1400s all the way through today. And if you just look at the time from kind of the 80s, the 90s, and into now, over the last 40 years, from, word processors and DOS and Macs coming into play, the internet, and all of the technology, what that is doing not only to our ability to provide care for people in better ways, to diagnose things better, but also for folks starting to say, is there an opportunity for me to get some of this healthcare outside of the healthcare environment itself as we used to know it? So we've got to be taking that into account as we think about what we're going to offer our communities going forward.
So in essence, the supply of new market competitors that are now technology based are saying, "Boy, I'm interested in making some money in the healthcare industry." And so Amazon, I'm not going to read all of this. You guys can take a quick look at it if you're not, clearing emails at this point. But just the trajectory between 2018 and 2026, where a technology-based company, Amazon, not only have they jumped in, but they're looking to fundamentally disrupt the delivery of healthcare services. And if you think they're slowing down in 2025, look at 2026, where they have just continued this acceleration of technology-based delivery. You've got CVS in primary care. Again, technology-based company. CVS jumped into this with their $8 billion acquisition of Signify Health. Then they acquired for 11 billion the Oak Street Health, a large primary care based division that makes their money by taking care of very sick patients and reducing the claims cost, which benefits their CVS managed care or insurance company. But CVS primary care jumps into this significantly. Then you've got people like United Healthcare. I don't know if you just saw that United Healthcare is now, they want to invest, I forgot the number, it's in the billions in AI. And if we think about why they're doing it, it's not to pay providers more money. I promise you that. But one of the things is, they became the largest employer of physicians in the United States. So United, largest health insurance company, became the largest employer of provider practices. Um, Several years ago, with the acquisition of Optum Care, that number I've heard is now over 70,000 providers, larger than Kaiser. They then spent they spent about 5.4 billion to acquire LHC, which is a large home care, and then just recently completed a purchase of Amedisys, another home care company. So, what's interesting about their play, if you think about it, United Healthcare, big insurance company, buying the front end of the delivery system, right? The physicians, buying the back end of the delivery system, right? If a patient slips through the physicians and gets into the hospital, now they've got, $8 billion of investment in home care to get the patients out as quickly as possible, and obviously to boost up their Medicare Advantage plans. But anyway, so United, big play here. You got Risant Health, and this is a really interesting market play. So this is Kaiser when they acquired oh
Geisinger.
gosh, Geisinger in Northeast and North in Central Pennsylvania. Geyser had a business model very similar to Kaiser, in which they had a number of primary care offices all over kind of central east Pennsylvania, with some hospitals, but a large insurance product. When Kaiser acquired Geisinger, they formed a company called Risant, who then last summer acquired Cone Health, another organization with a similar type of business model. So that's interesting. But what is more interesting is their intent in their saying that over the next 10 years, we want to acquire a number of health systems that have the same vision around, kind of revenue being insurance dollars, and then taking the revenue and investing in both healthcare and sick care resources to maximize that residual claim on health. So another market transformer in play.
Eric, I think
We've
one of the
got,
interesting things as we think
yeah,
about some of these, large Wall Street backed things, whether it's a CVS Aetna or it's, United Healthcare coming in, these folks, because of the access to Wall Street, because of the access to those billions of dollars, they see an opportunity out there. They jump on the opportunity. Not every one of them is going to hit. And so we do also see Amazon, another one. We're going to do Haven, we're going to do One Health, and then we switch out of it because they realize it wasn't exactly what we needed, but we're staying in the game. So there is investment and divestment as we go through. They can afford to do it. We have a harder time as health systems to be able to do that as well. But we're competing with folks that have virtually unlimited pockets.
very, very fair comment. And the classic example of entering and then exiting is Walgreens. We all saw that they made significant investments in in a physician practice, a large physician nationwide group, and then essentially disbanded it. So then there's this thing called AI. And, I was out in San Diego at the NRHA conference. I'm in a meeting in Washington, D.C. this morning. And this is a very popular topic of conversation. And a lot of it is some of the positive impact that we have, specifically around revenue optimization in assisting in revenue cycle and clinical documentation to fight claims denials is one big area we're hearing. The other is the helping physicians through the ambient listening and charting so that the physicians can save up to 2 to 3 hours a day in charting and be more there with their patients. I heard a speaker in San Diego talk about the fact that they were able to increase their patient load by 5 patients a day because of AI. Obviously, there's some concerns that are listed here, but AI game changer in terms of market transformation. Then we have this small little market phenomena called Medicare Advantage plans. And each year, MedPAC has really, in the last 3 years, MedPAC has released a study looking at the impact on the Medicare Trust Fund of these Medicare Advantage plans. But first, they start off with this, how many Medicare eligible patients are in the Medicare Advantage plans. That number has gone from 54% in 2025 to 55% in 2026. The interesting phenomenon is so to that point, we have now more than 50% of Medicare eligible patients in a Medicare Advantage plan, which is tough because it's one of the biggest challenges that we're hearing out there on the road is the fact that there's denied payment, delay payment, and underpay. Those are the big impacts on rural. So but no, this study is just looking at, essentially how the Medicare Advantage plans are overcharging the Medicare Trust Fund. The chart on the left shows that the black is just the cost of inflation that the trust fund is paying the Medicare Advantage plans. The lighter gray is the fact that the Medicare Advantage plans target market to the healthy Medicare beneficiaries, leaving the sicker ones in the trust fund, which means that if the trust fund is incurring more dollars on a per beneficiary basis. And then the white is the additional costs the Medicare Advantage plans have charged the trust fund by the first year, through kind of clinical documentation, getting the patients, even though they're the healthier population, to be 6% sicker in year one and 2% in year two. All in, the Medicare Trust Fund has spent close to $700 billion in extra dollars between 27 and 26. But again, the impact is deny, delay, and underpay. And we live in this world of fee for sick care. Price times volume is net revenue, right? Price times volume is net revenue. When we deny payment, we affect essentially payment, um, delay payment, we affect payment, and then underpay, we affect payment as well. So, a big part of that second, price times volume is net revenue, where price is being negatively impacted by our Medicare Advantage plans. So, as I just mentioned, we live in this world of price times volume is net revenue. What's going on with volume right now? And this is just trends going back across the United States. This is discharge per thousand. And if we took this back another 20 years earlier, these numbers would probably be in the 130s. But you can see that the trend on inpatient admissions per thousand has been a consistent downward trend, with the slight blip up in 2024. My understanding is this year we didn't have a flu season. These numbers are across the United States, and so these numbers are going to come back down for 2026. So here we are in rural healthcare. Price times volume is net revenue. We already talked about some of the impact of the Medicare Advantage plans on price, but now we look at volume. And so if we want to maintain revenue now, what do we do when we have inpatient volume going down over the years through trends like this? And most of us in rural say, well, inpatient's not that big of a deal. Outpatient is. And so this doesn't affect us that much directly, but the indirect effect is the big systems in the big cities that rely, 50% of their revenue is tied to inpatient services. And we're seeing these types of volume trends. The big city hospitals have to do something to make up. And it's increasingly challenging to just negotiate higher rates, especially with the impacts of the Medicare Advantage plan. And so it's a market share capture. It's a market capture. Grow your market. And that's the indirect that we're feeling in rural. So now outpatient, right? What's happening with outpatient volumes over time? And if you look pre-pandemic, this is ER visits per thousand. I'm using this as a proxy of outpatient volume. They hovered in this 140, 139, kind of in this range per thousand. The COVID, 2020, when we had that quarter where nobody went to the hospital, emergency room, unless they had COVID, and it went down and it's come back, mostly recovered, but the recovery rate is below where it was going in. Some of this would be probably attributed to the substituted, some of those new technology-based companies offering in to take some of these services. But now, if we look at this equation, price times volume is net revenue for our rural hospitals and outpatient services, in which 70 to 80% of our revenue is tied to, are starting to see a downward trend. What do we do? What do we do? And again, can we go to that price, right? The price times the volume is net revenue. Volume's going down. Can we go just negotiate a 10% increase with Blue Cross Blue Shield? Probably not the case.
Well, I think,
And
Eric, even when you look at someone that says, I may have a really high deductible to go to the emergency room. I've got $3,000 to go there. Is there an opportunity to go someplace else? Or not a $3,000 deductible there, but I've got a $3,000 deductible and a $500 copay. If I can find somewhere else, if there is somewhere else, we see folks leaving to get that diagnostic imaging, ambulatory surgery, all of the things that are eating away at the good payer margins of our rural hospitals. Those are risks for us. How do we deal with that? That's part of what we have to think through.
Yeah. And so overall, price times volumes net revenue, volume coming down. I always like to say, as long as we have an opportunity to grow market share and beat out some of those competitors that JD was just talking about, is an opportunity to stave off, kind of more challenging times. But let's talk about the other side of the equation. We talked about Medicare Advantage impact on price. Let's take a look at these Medicare margins. This is MedPAC puts out in their March 15th report every year, Medicare margins by hospital type. And if we look at all hospitals, the gray, we can see that the high water mark was about negative 5% Medicare margins in 2013. Then there was this decline. There was a slight increase, and then there was a sharp decline in 2022. And a couple things. One, I would attest that this decline between 2000 and kind of 12 down to here, I would say it came out of the Affordable Care Act when the government said, what we're going to do is we're going to pay inflation each year in our rate increases, our DRGs, our APCs, we're going to pay inflation minus 0.75%. And we're the government, so we're going to take off 0.75%. So they did that in 2012, didn't feel much. The next year, now the cumulative effect is negative 1.5. Then it started coming down to 2.25, then 3. Then the math gets real complicated. I'm not real good with math. But that number, that cumulative impact of paying less than inflation, so price is going up. So price is going down relative to cost, coupled with this decline in industry-wide volume that we started to see, especially inpatient, is part of this decline. Then we got to 2021 to 2022, and we had this decline where we're now negative 12%. Does anyone remember what happened in the fall of 2021 and through the spring of 2022? We were coming out of the pandemic. People hadn't spent money in 18 months. And at the same time, our supply chains were clogged because we had the Great Resignation. So what happened in a 6-month period, everybody in the hospitals industry's costs, everybody, that's too strong a word, a majority of people in the hospital industry, healthcare industries, costs went up 10% in a 6-month period. And it was just this mismatch between supply and demand. But the government had put out an increase of 2.3% was their fee increase. That was the inflation. Because the fact that this began October 1st of 2021 was essentially after the date that the government put out the fee increase. So we had, in 1 year, we had a 7.5% price to cost difference that to this day is still embedded in our payment system and causing some of the closures and service line closures that we're seeing today. Now, many of your critical access hospitals, hey, we got the increase because our costs went up 10%, Medicare paid us 10% more. Great. However, did Blue Cross give you a 10% rate increase? Did all your commercial, United, did any of those? No. So essentially, we even in the critical access hospital space got whacked by this. Excuse me. So anyway, so now we're looking at this. Volume as an industry is coming down. That's half the equation of price times volume is net revenue. And price relative to cost from your largest payers is going down. And now if you're the government, it was interesting because back in 2021, the former director of CMMI made a statement at a conference in April 2021. She said, "We can't have fee-for-service remain a comfortable place to stay." She also said that we need to have a clear path for the innovators who are ready and willing to take on risk. But I think we also need to push the laggers, and then we need to reach those having challenges participating in value-based payment is what she's referring to. And so if you're the government and you want to, kind of that proverbial frog swimming in a nice cool water in a pot on the stove, if you want to turn up the dial on the temperature in the stove And in your fee for service world, what do? Well, you reduce price relative to cost by 7.5%. And not that they did that, but their payment increase was 2.3% and cost went up 10%. That's how you make fee for service not be a comfortable place to stay anymore. So the second piece, how do we get the laggers to participate in value-based payment? Well, that year the government did these two things. Again, this was the price increase. The 2.3% was the DRG increase the same year everyone's costs went up 10%. The government is saying we are making the fee for service world uncomfortable. And then in that same year, the government said, hey, we want to create an ACO model for rural hospitals to participate in. And because we want them to be kind of at risk for, or not at risk, but at least responsible for the entire cost of care. And so they introduced this model for low revenue ACOs in which there was upfront a $250,000 investment, there was quarterly payments, et cetera, to get more people, the laggers, to participate in value-based care. Has that changed at all with the current administration? Not at all. The interest in ACOs and alternative payment models, accountable care payment models, is continues. Just in December of this year, or CMMI announced a 10-year model, the lead ACO, which has got a lot of very interesting features, especially for rural hospitals, especially those that have taken on risk in the past. They're looking to get, up to a $70 capitated payment to primary care practices. Now, some of that is base and some of it is at risk, or at least to be carved out of shared savings. But still, they're recognizing that we want to get folks into alternative payment models. And then if we look just back, I'm highlighting with my pointer this statement that the director of CMMI had said that ACOs represent a critical component of CMS's comprehensive strategy to increase value-based care for Medicare. This was just a couple of months ago that this statement came out. So current administration is all in. And if you notice just in this chart where my pointer is, you can see that the ACO kind of covered lives had declined, and now we're starting to see them bump back up again. And I think more and more people are starting to get more interested in alternative payment models. So the last part about where's the government is the Budget Reconciliation Act, right? This is HR 1. Um, uh, yeah, they're anticipating up to 15 million additional uninsured people coming out of the impacts of HR 1, whether that be through the reduction in exchanges or disenrollment from Medicaid. There was, there was an article that was published by the CMS that said that effective January 1st, we lost about 1.5 million enrolled lives from the exchanges. That was before people had started to receive their premium notices without the extension of the extended premium tax credit. And so now more recent studies, just in May, there was a study came out in Modern Healthcare saying that their expectation is the exchanges insured are going to be down about 26%. Okay, so less people with insurance. Again, price times volume is net revenue. The health sector is going to lose about 1.1 trillion. A lot of state-directed payments are going to be negatively impacted. It just came out in guidance and in regulation in the last couple of weeks. There is this access to rural transformation, but ultimately, if we live primarily in price times volume is net revenue, price is coming down in a number of different areas. One, you're going to have more people uninsured. So if they show up at the hospital to create volume, it's going to be either unpaid or underpaid relative to current. And then on the volume side is without insurance, or people are buying the bronze plans versus the gold plans. Under insurance, people are going to defer treatment, which is affecting the volume side of this equation. So this budget reconciliation, HR 1, OB3, whatever we want to call it, has really attacked our fee for sick care payment model. And that's why the comment we must proactively position ourselves for this new market reality. So, kind of in summary, that we believe fundamentally fee for service payment as we knew it in the past is going to be continue to transition to value-based payment or accountable care type payment. There will be increased pressures for operational efficiencies for all of the reasons that we just talked about. And then for rural hospitals, however we start to position for this future, there has to be flexibility because many of us, including me, that would have predicted this had come much sooner than it has. We don't know exactly when this change is going to happen, but the vector, the force in motion of an industry is in transition now. But we've got to, in order to be successful from a rural perspective, we have to integrate flexibility into the adoption of this future. So first part of the presentation, I talked about where the market's going, why the market's going there. The next is I'm starting to set the stage for why we think rural hospitals and health systems have incredible value in this new world. Starts off with this definition, right? The new competitive driver within the healthcare industry is patient value, defined by quality over cost times population. So anything that we do to increase quality, holding cost constant, improves patient value. Anything, ultimately the goal is to improve quality, reduce cost, applying it to a larger population, and that is the optimization of patient value. So with that definition, I want to create a second definition, and that's a payment system called accountable care. Don't think of it as accountable care like Medicare, but as a defined payment system where providers monetize the value of increasing quality, reducing cost applied to a population. So again, a definition in which provider organizations monetize, they create value to their own organization by increasing quality, reducing costs, and applying this value to the larger populations. So again, definition. And right now, that definition includes a lot of predefined models, whether it be bundled payments or the team model or CRJX in the future, value-based payment programs, self-insured health plans. Think of it. If we have a self-insured health plan and we improve the health of our workforce and reduce cost, the hospital monetizes that value. You have Medicare defined ACOs, and then ultimately capitated provider sponsored health plan. Think of the Kaisers of the world or the UPMCs or Intermountain Healthcares, in which if they can reduce the insurance premium, they benefit from that. The cost, they benefit. And many people are thinking, hey, Eric, we lived through this. It was called accountable care. Well, many of us lived through it. Some of us weren't born yet, but it was called managed care. And we just put our heads down and it went away. Well, this is why I think it's different. First of all, in the managed care era, the organizations that monetized that primarily benefited from it, that monetized the value of increasing quality, reducing cost, i.e., the insurance companies, had little ability to affect quality and cost. By definition, provider organizations now that have the greatest ability to affect quality and cost have the financial incentive to do so under accountable care. Second, the government's all in. We just showed you that the government, not are they all in, but they're pushing us. They keep turning up that heat on the stove of that frog swimming around in that kettle. They're the ones that are turning up that heat. So the government's all in. We have new information systems that we didn't have in the managed care era. We have a body of science to base medical decision making in that we didn't have in the managed care. And frankly, going back is not an option. I fundamentally believe that until the organizations that have the greatest ability to affect quality and cost have the financial incentives to do so, this continuing cost escalation will happen. And so this idea of jumping the S curve to me happens when we align payment with the payment incentives with the organizations that have the greatest ability to affect. All leading up to this comment that rural health systems have incredible value in the new world. And this came to me several years ago when I was reading the original ACO regs back 10 years ago. And there was a comment that jumped out. It said, a primary care physician can belong to one ACO, hospitals and specialists can belong to multiple ACOs. And I looked at that and I said, my gosh, that is why rural has incredible value in this new world. And so many of you are scratching your head, Eric, what the heck are you talking about? Here's what I mean. If you think about in today's business world, you have cost centers and you have revenue centers. And cost centers, essentially think about them, you can kind of cut up costs and spread it around to different revenue centers, right? You can just split up costs. Um, where revenue centers, you really have to attribute once to the organization. And so what this just to me said that your primary care physicians can belong to one ACO, hospitals and specialists can belong to multiple. What that said in its essence is in the future, primary care becomes your revenue center through patient attribution, where hospitals and specialists become cost centers. Revenue is tied to patient lives. Patient lives are tied to primary care through attribution. A busy primary care practice or physician with 2,000 patients, when the average per premium or per beneficiary healthcare costs are $10,000, is worth $20 million. Rural health systems that have strong relationships or employed relationships with their primary care physicians have incredible value in the future. And so the organizations, the rural health systems, we are fundamentally kind of primary care based delivery systems will have incredible value, especially when we're efficient and we have high quality. And so I believe that rural health systems have great value in the future. And so, again, building on this case of, okay, so we think we know where the market's going and why. We have value in this new world. How are we going to get to where we've got to be, where that value, kind of it comes down upon us? And so I want to start with this premise that form follows function follows payment, right? Think about that. Form follows function follows payment. We organize ourselves around the functional imperatives of the payment system. In the fee-for-service world, there's three functional imperatives: maximize price, sick care price, maximize sick care utilization, and minimize expense. And any organization operating on its own can be successful if it does that. And so the form we got out of the fee for sick care payment system was independent organizations competing with each other for market share. As we start to transition to these accountable care type payment systems and ultimately to population-based payment systems, the functional imperatives become very different. To some degree, we have to accumulate lives to be able to diversify that insurance risk. So we got to pull together lives. The second piece is that we have to be able to create enough resources to enable sick care and health care through an entire continuum of care. And we can't do that alone. We're going to need a hospital. We're going to need a tertiary center. We're going to need physicians and specialists and post-acute care and ambulance. And get ready for this, diet and nutrition, fitness all become part of this system. And to some degree, then the form is an aggregation of healthcare and sick care providers under an umbrella. And so, again, if the premise of form follows function follows finance, we are moving from a payment system that essentially rewards independence to a payment system that demands alignment. And so, so we better start thinking about payment as an important variable to how we think. And so if that's the case, several years ago, CMMI defined payment moving through a series, this continuum. The first is no fee for service, no links to quality and value. I would suggest that doesn't exist anymore in purity. The second is fee for service with links to quality and value. I would say 90% of us are here. 80% of us are here. The next one is alternative payment models built on a fee-for-service architecture. And then finally, full population-based payment. And I would say only a very few of us are here, probably one, which is Kaiser. Kaiser believes that revenue is premium dollars, and then they invest those premium dollars in healthcare and sick care resources to maximize the residual claim on a healthy population. And so here is the shaky bridge. Anyone who has not seen this, there it is in its full delight. Uh, After 1,000 words, this slide will be worth 1,000 words. But let me start with it saying and why it's so important is a graphic that you're never going to unsee at this point. Back to this, right here is the pillar of fee for service. So if we go back a slide, it's this orange right here, fee for service. It is a great pillar because payment and delivery are 100% aligned. The more sick care we do, the more money we make, and everybody is happy. Until price relative to cost is going down. Volume is coming out with new market entrants, with the challenges of the Medicare Advantage plans, et cetera. And this pillar starts to smolder. Over here, we have a payment system, a population-based payment. Going back to the prior slide, it's right here. Population-based payment on a population-based infrastructure. Perfectly aligned payment delivery. Everything that we do to create healthcare, reduce sick care, creates a better bottom line. Perfectly aligned delivery system, more healthcare, more profit. But in the middle is a mess. And let me kind of talk. So the fee for service, this is this payment system right here, which majority of us live in right now. And even if you say, hey, we're in an ACO, it's not core to your strategy. Most of us it's still about maximizing sick care. We still get excited for snow days in which people fall and break their hips. So here we are. We sit here right now. That's that second pillar, fee for service with links to quality and value. And our feet are above the crocodiles. We stepped off of this platform because it got too hot. The frog jumped out of the kettle and he's standing here. Here's the frog standing right here. The next pillar, right? Fee for service or alternative payment models built on a fee for service architecture. Your feet are standing right here, right above the crocodiles, because everything that we do to create health in our community gets CEOs and CFOs fired. So what do we do? We're standing here. As an industry, we're standing right here with a few exceptions. You got a couple different options. One is, do we go back, recognizing that this pillar is smoldering and it's getting pretty warm and the frog doesn't want to jump back in there? Do we go forward, recognizing that the CEO and CFO are going to get fired? Or do we do something alternatively? And I would suggest that there's something alternative that we can do, that we go forward, but we spend all the time we have right here, not only maximizing this payment system, but creating all of the infrastructures that when we hit here, it's a skip to something more permanent over here. Shorten the length of time that the CEO and CFO have the opportunity to get fired. And so several years ago, we came up with this framework, we called it. And it's a framework for how organizations really should think about this maximizing the current world and then skipping through the second phase to the more permanent phase. So if we align payment across the top somewhere, it used to be here. I don't see it. So pretend the x-axis is payment. Right here, we're going to place that first pillar of payment, which is just fee for service that doesn't exist. Here, we're going to have the one that exists today. So again, time coming across measured by the phase of payment. This is that second pillar of fee for service with tie-ins to quality and utilization. This is the feet right above the crocodiles, fee for service or alternative payment models built on a fee for service architecture. And then as we get out to here, we start to get beyond that towards more permanent population-based payment systems. So time measured by the payment system. If we come down the y-axis, there's three areas that a health system has to think about and think about simultaneously. We have to pick up and transform our sick care system. There are three initiatives to do that. We have to create a healthcare system. And when we create healthcare, as we evolve across payment, we have to crawl, walk, run, sprint. If we come out too fast in racing to create healthcare when we're still getting paid in fee for service, we close. And then we have to pick up and transform payment. There are three initiatives to transform payment. There's one more thing I want to explain Coming down is the orange bar. This is the strike point. So when the initiative hits the strike point, it's a do. This next one, kind of first one, operating efficiencies, quality, patient engagement, implementation. So it's an implement. We've got to improve our operation efficiencies, quality, and we have to proactively engage patients. The next is fundamentally aligned with primary care because when the payment system gets out to the second phase or the third phase, primary care is your revenue center. We better be aligned with them. So today we plan to strike. And then finally, service area rationalization. Taking out big chunks of fixed costs, when payment gets out to here, are bricks and mortar specialists and technology, right? And so essentially this first initiative, one, has to be implemented immediately. This one is in the future, and this is the distant future. All of these steps to transform sick care. Around picking up and moving payment, let's start all the way down at the bottom. If we have a self-insured health plan, what have we done to enroll all of our workforce in our care management models? What have we done to create incentives in our plan so that patients are encouraged to do healthy elective behavior and use our hospital? And then all the opportunities around quality utilization, annual wellness visits, chronic care management, anything we can do to get paid for healthcare in the sick care payment system that we predominantly live in. Transitioning payment models. These are your low risk ACOs, a plan to implement here, and then finally full risk plans, strategy, implementation, and strike point. Around healthcare, again, crawl, walk, run, sprint. Today we build the infrastructure, patient-centered medical home or like this proactive outreach to patients, care management models, data analytics, evidence-based protocols, crawl, walk, run, sprint. But in the end, when sick care, the first three rows, payment, and healthcare come on one umbrella, we have the Kaisers of the world, provider-based health plans, which we believe is the tip of the spear sometime in the distant future. So what does all that mean? And I just want to go through these couple slides here and then summarize. So initiative one, if you look up in the top right corner, this is row one. Essentially, hospitals not operating at efficient levels are going to struggle, especially with HR1 and some of the impacts of the bill. And efficient means a number of things. Appropriate patient volumes meeting needs of the service area. One more. Right now, the weapon that we have in our health systems in this predominantly fee-for-service payment system is contribution margin. One more admission built on a 90% fixed cost base drops a 90% contribution margin. One more clinic visit. So instead of 15 patients a day, we do 16 patients a day. If our fixed costs on average, this is based on a study by the University of Iowa last year, our fixed costs average about 90%. It is the weapon that we have, and having appropriate volumes meeting the needs of our service area is your opportunity. Revenue cycles operating, I'm seeing revenue cycle practices. I've just been at a couple of hospitals recently where revenue cycle just about took hospitals down. Poorly run revenue cycle. Expenses managed aggressively. Just because we're a critical access hospital does not mean that we shouldn't be managing expenses. It's just as important. Physician practices. We've got to get practice management expertise. And then leveraging AI to improve operational efficiency and reimbursement. All of these is defining efficient. The next bullet, patient engagement. I want to start having all of our rural healthcare systems stop thinking of our community as patients, start thinking of them as people. And what happens is the funnel into our health system quadrupled in size when we start being proactive around our population as people rather than waiting for them to become patients. Think about that and I hope you can all have good conversations about what that means with all of the new payment systems or payment vehicles to pay for wellness and outreach. This was the study that I was just talking about. This was a study came out by the University of Iowa last year, School of Public Health, where essentially rural hospitals, these are very small rural hospitals. The column that's relevant is this right here, where they looked at the very fixed costs of hospitals. Smallest hospital, small, medium, large. And what they showed is that the smaller the hospital, the higher the percent of fixed costs, meaning the higher the contribution margin is for one more visit, one more patient day, etc. Quality. We've got to be able to get to the point where we compete on quality as a competitive driver. And I know, JD, you wanted to comment here.
Yeah, I think it's important, to recognize that oftentimes we look at ourselves as small rural hospitals, critical access hospitals, and we say, well, we can't do what the big systems do. They've got their X, Y, and Z. And this is, I just think, a really, really poignant example of a client in Massachusetts, all the way on the left-hand side. They are in far western Massachusetts, critical access hospital. Their inpatient units are from 1928 and the 1960s. And all of the other hospitals are some are smaller, but then we've got Mass General building a $2 billion tower right now. And Fairview Hospital in Great Barrington, Massachusetts, a critical access hospital, has higher HCAP scores than anyone else across every single one of the 10 metrics in there. And it's not just about, having the access to a beautiful building. It's all about the mentality. It's about the expectation from administration and the staff that forget about what our assets are. We are going to deliver it better. So their rooms are always clean. They're always quiet. Even though they have some semi-private rooms, they're still able to engage with their patients and focus on that quality as a strategic imperative and a competitive advantage.
Thanks, Chief. Right on. The second one, and if we walk out of this presentation forgetting the other 40 slides, I think this one is super important because this is one, alignment with primary care. This is one of these, if you don't, this is don't pass go, don't collect your $200 as it relates to participating in value-based accountable care payment systems of the future. So first and foremost, let's all understand that revenues streams of the future are going to be tied to primary care, physicians/providers through patient attribution. And again, as I mentioned, that a busy practice a nurse practitioner, a physician, care coordinators with 2,000 active patient panels. If health insurance or per capita healthcare costs are 10,000, it's more than that, but I'm trying to keep the math easy. I told you I'm not good at math. Is about $20 million for one practice. If we in a rural hospital have 5 busy primary care practices, we have an upside value of 100 million for probably direct costs of 40 million. Huge value in this new world. The second thing I'd just like to have you think about is your relationship with your physicians, primary care, but also your specialists. And I want to borrow from Stephen Covey and his models of dependency here, right? So he's got dependent, your 5-year-old, independent, your 18-year-old, and interdependent, your 26-year-old. And we really want to move from dependent to independent to interdependent. I look at all members of our medical staff from the perspective of fundamentally independent, and could go anywhere they want to go. And so if we want to create this higher level of relationship, this interdependent model, what we've seen work best is a 3-legged stool of contractual alignment, functional alignment, and governance alignment. And almost kind of inventory your medical staff. Where are we on our contract? Do we have a best practice employment agreement? If not, if we have a bunch of independent physicians in town, can we create an old PHO model or a clinically integrated network model? Function, where are we from a delivering of care functionally? Joint developments of evidence-based protocols, shared medical records, and then governance. What is our medical staff's participation in executive leadership board, etc.? I have a hospital. A friend of mine runs a hospital in the Midwest. It's a critical access hospital. He employs 102 providers, and this gentleman will say, we are a provider-led organization, completely embracing it, his medical staff as partners rather than as employees. Super, super important. This next one, this is the third row down, in which rationalized service area, coming together to take out big chunks of fixed costs. A majority of those fixed costs are not in rural America. They are in the big urban centers that have built their infrastructure to compete with their neighbor down the street. And so What I'd like to have us think about in rural is there that three-legged stool of interdependence that we could create relationships through function, governance, and contracts that could stand the pressures of an evolving payment system? One opportunity that I'm seeing pop up all over the country is the clinically integrated networks, statewide clinically integrated networks. What an opportunity to bring together organizations around this interdependent model of alignment. And to this day, I still think these models have yet to be developed because the payment system hasn't been right for them to be developed the way uh, to meet the needs of these new accountable care payment models. Payment system dropped all the way to the bottom now, right? So we're all the way down here. It's hit the orange bar. It's a strike point. So what are they? Self-funded health plan. Many of our hospitals, even our rural hospitals, have self-funded health insurance plans. What are we doing to look at the claims? What are we doing to actually consider our employees and their dependents enrolled in our plan? What are we doing to think of them as an at-risk population that we're looking to improve the health of? We're looking to manage claims better. And how are we thinking them as an opportunity to learn how to care for the risk? So many hospitals are not even looking at claims. So many hospitals are not looking at outmigration. The greatest opportunity that you have to benefit in your self-insured health plan initially is to reduce outmigration. Again, if you can provide the service, it's a 90% contribution margin versus if you send it down the street where it's 100% loss. And then maximize all the opportunities. Again, this is that opportunity to create our community as people versus patients, where we can maximize annual wellness visits, chronic care management, transitional care management. I would love to have every hospital actively manage their patient panels, identify patients, identify their active patient panels, and then look to grow those over time. And whether it's a 12-month active patient definition, 18-month, but how are we going to get there? The second phase is implement. This is around transitional payment models, the ACOs. Let's hold off on there just because we only have 3 more minutes. And then the blue bar in the middle. So right here, we're going to just focus on column one, payment system that exists today. And do we have patient-centered medical home designation or at least like structure that enables that proactive outreach to our people versus our patients that present when they get sick? Care management, discharge planning across the continuum, and transitions of care. All of these are opportunities. Claims analysis capabilities, starting with your self-insured health plan, looking at your ACOs. But we really should, when we shine a light on where patients are receiving care, the care levels that are received, we shine a light on that with data, it changes decision making. And then working in partnership with your medical staff around evidence-based protocols and having them throughout this continuum.
I
So
think one of the key things is that, as we think about this framework, it's often something when we say, hey, how do we go from here to there? This is a framework you can use if you believe in it. If you believe all of the things that Eric's been saying for all of these years, this is a framework you can use to think about your own strategic planning. For the last 8 or 9 years, all of the strategic planning that I've been doing with Eric has organized the plan around these 5 themes, around the operating efficiencies, the here and now. 70% of everything we're doing is still there because that's how we're going to make our money today. But as Eric said, we need to be positioning ourselves for the future. We are aligning with our providers. We're not engaging in the medical arms race of, I need to have this so that somebody else doesn't have it. We're thinking about it as an overall network while we build that population health infrastructure and at the same time walk our payment system along through there. So, this is certainly a tool that you can use as pillars, as themes, as an organizing process for your own strategies going forward.
And thanks, JD. And the real again, what I want to emphasize is this: the reason why this is red box, this column one. So this again is currently the here and now, the payment system of fee for service with tie-ins to quality and utilization. And it's a 2-for opportunity. The first is to maximize everything that we do going down these 7 rows, maximizes this payment system. And it creates the options so that this pillar becomes a skip step rather than a long stay getting CEOs and CFOs fired. So this is everything. We got to stay here as long as we can, doing the maximizing the payment, but creating the infrastructure to skip step this next one. That's a really important thing. So just wrapping up here, I got 2 slides. I might have to beg you for one more minute of your time. Um, obviously, this in rural healthcare, we've had challenges throughout. Tough recruiting, often limited cash reserves, facilities that are not necessarily where they should be. Those were all challenges, but I think the challenges of transitioning this shaky bridge is going to be our toughest one left. Good news is that healthcare is delivered locally, um, and that the shaky bridge, it's just not going to be able to skip across it without any thinking. We've got to be proactive and proactively maintaining alignment between sick care, healthcare, and payment as we move across those phases of payment. And so, what do we do immediately? Well, let's get more people interested in understanding these new environmental realities, making sure that your plan has some type of a bridge strategy in it. In other words, that you're not doing something that precludes you from that skip step and that not participating in the future. For example, let's just say, hey, we want to get rid of all our primary care physicians because they're losing money on us. That would be completely against positioning for a skip step in column 2. And improve operational efficiencies. We talked about that. And as JD talked about, quality and really kind of using quality as a competitive driver. Align partner with medical staff through this interdependent model of contractual, functional, and governance alignment. Same type of thinking around developing systems, and then start thinking about moving proactively towards value-based payment. And so I like to conclude this presentation, by saying that I'm an accountant. I should have warned you that before we started, but I'm an accountant. I wanted to be an accountant in 10th grade. And to some degree, I'm ashamed out of our accounting industry that designed a payment system that rewarded sick, because what we got was a lot of sick, because everybody wins when we're sick except for society. I see the future where a payment system does not preclude an equal investment in healthcare as it does sick care. And I can see what that looks like, 10 years from now, when there's all of the resources that we've almost singularly applied to sick care are spread between healthcare and sick care. And I see a different society, both in our rural communities and all of our communities across the country. Frankly, I want to be part of that, and everyone at Stroudwater wants to be part of that. And so appreciate all you guys listening. I know we're about 3 minutes over. Apologies for taking up an extra bit of your time. And as JD mentioned, we're going to get to all your questions. I'll respond to those. It might take me. I've got a crazy travel schedule recently, but we're going to get those questions responded to. And I appreciate you guys listening. JD, you want to say anything?
No, I think this is such an important topic, and I'm glad that you remain committed to it. I know you could be doing something more fun, perhaps, than dealing with rural strategy all day long, but it is who you are. And so I appreciate you. I appreciate you letting me join you, and I look forward to seeing many of the folks on this call out at various events and in your facilities. Let's keep rural healthcare alive, because it's a huge part of who we are as a country.
Thanks, JD.
All right. Thank you, Eric and JD. Folks, if you have any questions while I wrap up here, you can put them in the QA. We'll make sure that we get back to you. Just a few housekeeping notes. The slides on the presentation will be made available to you after this. So look forward to that. To all of our attendees, we really appreciate you spending time with us and giving us part of your day. And thank you for your continued commitment to serving our rural communities across the country. So today's conversation highlights some of the biggest issues facing healthcare right now, rural healthcare, including workforce sustainability, organizational risk, long-term strategic transformation. But we also reinforced opportunities that you have to strengthen performance through innovation and partnership and community alignment. As a reminder, when you close out of today's session, you'll receive a brief survey pop-up. We really appreciate the feedback. We'll only take a minute, and it helps us plan for next time. We hope to see you again tomorrow as we continue this conference. We have additional sessions focused on practical implementable strategies for rural healthcare leaders, including service line development best practices, and then about building a swing bed program to improve healthcare delivery, and then one on leveraging RHC flexibility to expand specialty services. And all that kicks off at 11 a.m. tomorrow. That
Eastern
is
time.
all we have for
Eastern
today.
time.
That
11
concludes
a.m. Eastern, Keith.
Eastern, 11 a.m. Eastern, yes. That concludes day one of our conference, and thank you again, and we hope to see you tomorrow.
Wow.
Cheers. Thanks, everyone.